You know that feeling when you want to get your head around something complex, but without wading through tons of jargon?
Yeah, exactly.
That's what we try to do here. Today, we're diving into something pretty specific about our dogs and cats. Ductal Plate Malformations. DPMs, for short.
Right. It sounds technical, but it's basically about how a particular part of the liver develops or sometimes doesn't quite develop correctly.
Okay, so we're looking into what these are, why they happen, the different kinds, how vets figure them out, and what can actually be done.
Precisely. We've gone through some pretty detailed medical texts to pull out the key stuff.
Yeah.
It's a specific kind of liver development issue, like you said, but it can cause a surprising range of problems.
All right, let's jump in. Ductal Plate Malformations, DPMs. What are we actually talking about in simple terms?
Okay, so at its core, a DPM is a liver problem we see in young animals. It's not caused by inflammation.
Right.
And the really key thing, it's congenital. They're born with it. It's not something they catch later.
So a developmental glitch from the start.
Exactly. It stems from abnormal development of the biliary structures, that whole network of bile ducts inside the liver.
Like the liver's internal plumbing system going a bit wrong during construction.
That's a perfect analogy. And it all seems to trace back to this early structure called the ductal plate.
The ductal plate.
Yeah, it's the embryonic tissue that's supposed to develop into the portal, tracks those areas with blood vessels and bile ducts and the bile ducts themselves. And what's really interesting, research in humans and even in mouse models points to gene mutations.
Gene mutations affecting what?
Affecting primary cilia.
Primary cilia. Remind us why those are important again. They're tiny, right?
Tiny, yes, like little antennas on cells. They're solitary, they don't move like other cilia, but they're crucial sensors.
Sensors for what?
For all sorts of things, mechanical forces, fluid balance, chemical signals. They help control how cells are oriented, how they divide, and they're involved in loads of cell signaling pathways.
Wow. So a problem with these microscopic antennas during development can mess up the whole plan for the liver's plumbing. It's amazing.
It really is. A key mechanism seems to be interrupted tubulogenesis.
Tubulogenesis. Tube formation.
Exactly. The process of forming those bile duct tubes gets disrupted. And we see a really clear link, for example, in Persian cats. You know how some get polycystic kidney disease?
Yeah, that's genetic, isn't it?
It is. And about 15% of those cats also develop these hepatic DPMs. It strongly suggests there's a shared faulty pathway in development.
Okay, so it's a developmental error in forming bile ducts, possibly linked to these cilia. Now, you mentioned there are different types, different phenotypes, 4 main ones and a related 5th.
That's right. They present differently. First, there's the caulodocal cyst.
Caulodocal cyst, what's that?
Think of it like a little pouch or a diverticulum bulging out from the common bile duct or the cystic duct.
Okay.
The big worry with these is infection. The sources we looked at even compared it to appendicitis.
Really? Appendicitis?
Yeah, because if it gets infected, it can lead to sepsis, a really serious body-wide infection, or block the bile duct. Sometimes you might even feel a mass in the abdomen.
Oof, sounds nasty.
Okay.
Okay, what's the second type? Caroli's malformation. Sounds almost musical.
Hey, the name, maybe, but the condition, not so much. Caroli's involves irregular widening, sort of sac-like bulging of the bile ducts inside the liver itself. Both large and small ducts can be affected.
So ballooning ducts within the liver.
Kind of, yeah. Microscopically, they can look really varied, stretched out, irregular, definitely sacculated. And the problem is stuff can build up in these widened ducts over time.
Like debris.
Debris, yeah, which can then form gallstones, cololiths, or even mineral deposits. And just like the cysts, they're prone to infection, which we call cholangitis.
Cholangitis, inflammation of the bile ducts.
Exactly. And sometimes this is first picked up almost by accident on an x-ray if there's a lot of mineralization, leading to this term limey gallbladder.
Limey gallbladder.
Yeah.
You weren't kidding about graphic terms. Okay, third type. Diffuse intralobular bile duct malformation. Sometimes with, sometimes without, congenital hepatic fibrosis, or CHF. That's a mouthful.
It is. Let's break it down. Diffuse means it's widespread in the liver.
Right.
The idea is that during development, some extra bile duct precursor structures that should disappear don't. They get reabsorbed normally, but here they stick around.
Okay.
So you end up with lots of these small, malformed little ductules, which often don't connect properly, and they're embedded in too much connective tissue, like extra scaffolding, the extracellular matrix.
In the CHF part, the fibrosis.
Right. So if you get this Proliferation of ductules plus an increase in blood vessels and that matrix scaffolding, it expands the portal tracts. You can even get fibrous bridges forming between portal areas. We call that portal-to-portal bridging fibrosis.
So scar-like tissue building up.
Essentially, yes.
Yeah.
And in these CHF cases, the portal veins, which bring blood to the liver, can actually become hard to see because of all this extra tissue.
And what does all that fibrosis, that hardening, lead to?
Big problems, potentially. This dense fibrosis can cause something called presinusoidal portal hypertension.
Portal hypertension. High blood pressure in the liver's vein.
Exactly. But before the blood gets to the main filtering units, the sinusoids, it's like a blockage upstream. And this back pressure can force the body to create detours, acquired portosystemic shunts, or APSS, abnormal blood vessels that let blood bypass the liver altogether.
So the liver doesn't get to filter the blood properly. That sounds serious.
It is, because toxins don't get removed effectively. Okay, next up are von Meyenberg complexes, VMCs.
These sound maybe less dramatic?
Generally, yes. They're basically tiny microscopic clusters of those abnormal ductules in small patches of connective tissue, also called bile duct hamartomas.
Hamartomas.
Well,
like benign growths.
Sort of, yeah. The good news is they're usually considered inconsequential. They don't tend to cause major health issues on their own.
Okay. A bit of relief there. And the fifth related condition, progressive presinusoidal fibrosis.
Right. This one's interesting because it can happen even without that widespread duct malformation we just talked about. Some animals just develop increasing fibrosis, that scarring, in the liver as they get older.
And this still causes problems.
It can, yes. It can still lead to that same portal hypertension, the acquired shunts, APSS, fluid in the abdomen, which is called ascites, and those neurological signs, hepatic encephalopathy, from the toxins building up.
Okay, so we have these different patterns, these phenotypes.
Yeah.
How do they actually show up in pets? What signs would make you suspicious?
That's the tricky part. Often, these DPMs are, silent initially. You might not see the classic signs of liver disease like high liver enzymes or jaundice.
The yellowing?
Right. Not until a complication happens, like an infection kicks off in one of those abnormal ducts or gallstones cause a blockage.
So the underlying defect is quiet until something else triggers symptoms.
Pretty much. The body compensates, sometimes for a long time. And which signs you see often depends on the type of DPM. So like we said, colodocal cysts often show up when they get infected. Corolli's might be an incidental finding on an ultrasound, or it causes issues when stones or infection develop.
Makes sense.
And that diffuse type, without much fibrosis, it might only get diagnosed if there's an infection causing liver enzyme spikes leading to a biopsy. But if there is significant fibrosis, the CHF type.
Then you see signs of the portal hypertension.
Often, yes, like the ascites, that belly fluid.
Gotcha. So what are the specific signs owners might actually notice across different systems?
They can be really varied. In the liver itself, a vet might feel an abnormal liver size, small, normal, or big. Maybe gallbladder issues, jaundice if bile flow is blocked, higher enzymes if there's infection. GI signs like poor appetite, vomiting, diarrhea, sometimes linked to the high pressure in the gut. Neurologically, you might see confusion, disorientation, those hepatic encephalopathy episodes.
Right, the brain effects.
Yeah. Maybe poor growth, poor body condition. Some drink and pee more, possibly due to kidney links or the shunts. Certain bladder stones can form too.
Bladder stones. Interesting link.
Yeah, specific types. And blood work might show small red blood cells, which can suggest shunting, or high white blood cells pointing to infection.
It's a wide range. Is there a typical age?
Often diagnosed in juvenile to young adults. The data suggests maybe a mean age around 1.5 to 2.5 years in dogs, but it varies.
Any breed connections?
Potentially boxers, and definitely Persian cats with that polycystic kidney disease link we mentioned. But it's really important to remember some animals can have DPMs and show absolute no signs. They're asymptomatic.
Right. Okay, so if a vet suspects DPM, how do they confirm it? Diagnosis must be tricky.
It involves ruling out a lot of other things. First, other kinds of liver shunts, different causes of liver inflammation, toxins, even heart problems if ascites is the main sign.
So differential diagnoses, what tests are key?
Blood work and urinalysis are crucial starting points. Looking for those small red cells, liver enzyme changes, bilirubin levels. In cats with CHF and shunts, you might see specific urine crystals, ammonium biurate. Measuring total serum bile acids, TSBA, is really useful. High levels often point towards shunting, blood bypassing the liver.
Bile acids.
Yeah, they should be processed by the liver, so if they're high in general circulation, it means the liver is likely being bypassed. And if there's fluid in the abdomen, analyzing that fluid helps figure out why it's there.
What about looking inside? Imaging.
Oh, absolutely critical. X-rays might show liver size changes, fluid, maybe those bladder stones.
Right.
Ultrasound is usually very helpful. You can see the liver texture, the bile ducts, look for cysts, stones, assess blood flow.
Ultrasound seems key.
It often is. Then there's scintigraphy, a nuclear imaging scan, which is very good for confirming shunts.
Yeah.
But probably the gold standard for mapping out the blood vessels and liver structure in detail is a multi-sector CT scan.
GT scan. Got it.
That gives a really clear anatomical picture, great for confirming shunts and other malformations. And ultimately, the liver biopsy, yes. Examining the actual tissue under a microscope is the definitive way to diagnose DPM. Just sucking out a few cells, a fine needle aspirate, usually isn't enough information.
Okay. Biopsy for confirmation. So once it is diagnosed, what's the treatment plan? Can you fix it?
You can't really fix the underlying developmental defect in most cases. Treatment focuses on managing the complications and supporting the animal.
Right. Managing the consequences.
Exactly. So if there's severe infection or bad neurological signs, they'll need inpatient care, IV fluids, intensive support.
Hospitalization.
Yes. For colodocal cysts, surgery is often the way to go. Either remove the cyst entirely or connect it to the intestine so bile can drain. The sources specifically warn against trying to use alcohol ablation on these.
Okay, surgery for the cysts. What about stable patients managed at home?
For stable animals, the focus is prevention and prompt treatment. Prevent parasites and treat infections quickly because these animals, except maybe those with just VMCs, are more prone to cholangitis.
More susceptible to bile duct infections.
Yeah. Right. And for those with CHF, the fibrosis type, you need to watch out for those specific urinary stones. And definitely avoid NSAIDs if there's ascites.
Why no NSAIDs with ascites?
They can make fluid retention worse and increase the risk of GI bleeding, which can then trigger hepatic encephalopathy.
Ah, okay. And managing that encephalopathy.
The neurological signs.
It involves tackling any underlying trigger, like infection or bleeding, adjusting the diet, often lower protein, but high quality, maybe vitamin supplements, and then medications. Lactulose is common. It helps trap toxins in the gut. Certain antibiotics can also reduce toxin production by gut bacteria.
Lactulose and antibiotics. And the ascites, the fluid.
Usually managed with dietary sodium restriction, less salt, and diuretics like furosemide or spironolactone to help the body get rid of excess fluid. Sometimes you need combinations or other drugs if it's resistant.
Are there any drugs that target the fibrosis itself? The scarring?
That's a tough one. In humans with DPM, traditional anti-scarring drugs haven't really worked well for the fibrosis part.
But the sources mentioned one drug, telmisartan. It's an angiotensin receptor blocker used for blood pressure in people. It's shown some promise in animal models of similar conditions.
Telmisartan. Interesting.
Yeah, it might have other benefits for liver and kidney health, too. Antioxidants might also be used sometimes, especially with chronic cholangitis or CHF. You also need to be mindful of potential bleeding issues, though rarer in CHF unless there's bile duct obstruction, and manage any gut bleeding if it occurs.
And I guess you have to be careful with any medications.
Absolutely. Avoid drugs that are heavily processed by the liver or that could interfere with the meds they're already on for complications.
Makes sense. So looking long-term, what's the prognosis? What kind of follow-up is needed?
Regular checkups and monitoring are key. Periodic blood work to catch complications early.
Right.
For those with CHF and hepatic encephalopathy, it's often lifelong management. But, and this is important, long-term survival is possible. We're talking potentially years.
That's encouraging.
It is. But ongoing treatment is usually needed, maybe antibiotics long-term or intermittently, potentially antifibrotics like telmisartan, diet changes, meds for the neuroscience and ascites. And flare-ups can happen.
Flare-ups requiring adjustments.
Yeah, sometimes needing hospitalization again to get things back under control, adjust diuretic doses, manage an encephalopathy episode. It requires ongoing vigilance.
Okay, so wrapping this up, DPMs are these really quite complex developmental liver issues in dogs and cats. Lots of different ways they can look, and the key seems to be understanding those forms and watching out for the knock-on effects, the complications.
Exactly that. And it is pretty amazing how these structural problems can just sit there silently until something else goes wrong. It really shows you how resilient the body can be, how well it compensates, for a while anyway.
This has been incredibly insightful, really fascinating stuff, and it makes you wonder, doesn't it? Thinking about that link to primary cilia, which do so many things.
Yeah.
What other conditions, maybe seemingly unrelated ones, could have links back to these kind of subtle developmental glitches?
That's a great question. It definitely highlights how interconnected everything is in biology. You tug on one developmental thread, and you might see effects you didn't expect elsewhere.
A perfect thought to leave our listeners with. Thanks so much for walking us through all of this today.
My pleasure. It's a complex but important topic.